नमस्कार दोस्तों, as we discussed in the last video, cast, splint, and the traction, the very important complication which occurs if we put the tight cast or tight traction, then development of compartment syndrome. So, compartment syndrome not only developed by the cast, traction, or other means it can directly develop if there is a trauma, severe trauma with severe soft tissue injury. So the learning objective of this video is define the compartment syndrome, explain the pathophysiology, identify cause and risk factor, recognize the clinical feature and diagnose the compartment syndrome, understand the emergency management indication for fasciotomy and the complication of delayed treatment. So, introduction, it is a life threatening orthopedic emergency caused by increased pressure within a closed fascial compartment, leading to impaired tissue perfusion. If not treated promptly, it can result in irreversible muscle and nerve damage within hours, causing permanent disability or even limb loss. A condition, by definition, it is a condition in which increased pressure within a closed osteophysial compartment compromise the tissue perfusion, leading to ischemia of muscle and nerves. The normal compartment pressure is around 0 to 10 mmFg. If the pressure is more than 30 mmG, or a delta pressure, diastolic blood pressure minus compartment pressure, is less than 30, which may indicate the need for fasciotomy. But the clinical finding remains the most important determinant for the fasciotomy. For any compartment of the any limb, there is a bone, there is an interosseous membrane, facial septas, deep fascia. These structures are non-expandable. So any increase in compartment volume raises the pressure. Common site which develops the compartment, leg is the most common because it has the four compartment: anterior, lateral, superficial posterior, and the deep posterior. In the forearm is the second most common. It has the volar dorsal compartment on the mobile vein. Mobile vein are brachioradialis muscles, ECRB and ECRL. These three muscles form the mobile vein of forearm. Other sites which can develop the compartment are hand, foot, thigh, arm, gluteal regions. These are rare sites. The causes of the compartment syndrome, the traumatic causes are most common, like tibial shaft fracture, forearm fracture, crush injuries, high energy trauma, or multiple fractures. Vascular causes that can lead to compartment syndrome are reperfusion injury, arterial injury, vascular surgery. External causes, in vascular surgery, whenever there is a vessel cut or vessel arterial injury, when we repair such injury after a long period of time, then these patients can develop the compartment syndrome. External causes are tight cast, tight splint, circumferential burns, pneumatic compression. These we already discussed in the previous video. Other causes are snake bite, hemophilia patient, anticoagulant therapy, and intramuscular injection. These are rare cases. In the pathophysiology, whenever there is a trauma lead to bleeding and the edema of that part of the limb, or an increased bleeding edema leads to increased compartment pressure. Increased compartment pressure leads to reduced capillary blood flow and the muscle ischemia. Then nerve damage and the necrosis of this tissue and the permanent disability. This is the, if we do not intervene the process of compartment syndrome, then such things happen. The clinical features, the classical 6 P's. Pain is the earliest and most important sign. It is the severe pain, is the pain out of proportion to the injury, and pain increase with the passive stretching of the muscles by passive movement of the limb by toes, passive movement of the ankle and raised hand, whichever part is affected. Second one is the pale skin, reduced because of reduced perfusion. Paresthesia, tingling, numbness, these are early neurological sign. Then the paralysis, this is the late sign, indicate the muscle ischemia or nerve damage. The pulselessness is the very late sign. Presence of distal pulse does not exclude the compartment syndrome. The poikilothermia, affected limb becomes the cold. Earliest clinical sign is the pain on passive stress. This is the most sensitive early clinical finding. In the physical examination, you will see there is a tense, swollen compartment, severe tenderness, pain on passive stress, reduced sensation, and the weakness, such as shown in the image. This is the leg of the patient with showing the tense swelling because the skin is shining, tensed with lot of swelling. Diagnosis is the clinical diagnosis, most important. Diagnosis is mainly based on the history, examination, and high index of suspicion. Compartment pressure measurement. It the indication of measurement are unconscious patient, polytrauma patient, equivocal clinical finding. Common methods we use are needle manometer or commercial pressure monitoring systems. So differential diagnosis. In compartment syndrome, you have to exclude the deep vein thrombosis, cellulitis, arterial occlusion, peripheral nerve injury, or muscle strain. Emergency management. Step 1. Suspect the compartment syndrome. Do not wait for loss of pulse. Step 2. Remove external compression, split cast, loosen bandage, release tight dressing. So first, if you suspect, do not wait for the loss of pulse. Remove. Next step, you have to act. If there is a tight dressing, then remove the external compression. If there is any cast, split the cast. Tight bandage, loosen the bandage, release the tight dressing. These are steps. Then position the limb at the heart level. Avoid elevation well above the heart, may reduce the arterial inflow. Avoid dependent positioning, may increase swelling. Step 4. Provide analgesia, urgent orthopedic and the vascular surgeon consultation. In the emergency fasciotomy if required, which is the definitive treatment for compartment syndrome. Fasciotomy. It is the surgical decompression of all involved compartment by dividing the fascia. The basic indication of clinical compartment syndrome: raised compartment pressure with compatible clinical finding. Principle: release all the compartment at risk. Example: in the leg, all 4 compartment fasciotomy. In forearm, volar and dorsal compartment release as indicated. If you did the fasciotomy, so how will you manage further which are created surgically wound? So you will leave the wound open initially. You wait for 1 week or 2 week. You will do the sterile dressing or negative pressure dressing may be used to decrease the size of wound. Then delayed primary closure or the split thickness skin grafting after swelling subsides. Complication of delayed treatment: there is a muscle necrosis which occurs after prolonged ischemia. Nerve injuries: nerve injury can lead to sensory loss or motor weakness. One of the important complication is Walkman ischemic contracture. That is commonly affected is the forearm. It leads to the flexion deformity, clawing, muscle fibrosis. Why? Because the flexor compartment is more prone to ischemia or to develop compartment syndrome than the dorsal compartment. Patient can have chronic pain, infection, limb loss in untreated case, or acute kidney injury due to myoglobinuria from rhabdomyolysis. time is the muscle. Why? Because timing is important in the compartment syndrome. Nerve usually in 2 to 4 hours. There is a functional changes in the nerve. Irreversible injury occurs after 8 hours. Muscles irreversible injury necrosis become increasingly likely after 6 hours of severe ischemia. So, clinical case. A 24-year-old male sustained a closed fracture of the tibial shaft. 6 hours later, he developed severe pain despite analgesics, increasing pain on passive movement of the toe and the tense swollen leg. The distal pulses are present. What is most likely diagnosis? So likely diagnosis is the, as we are discussing, the compartment syndrome, because there is a severe pain, there is a history of trauma, and the pain on passive movement of the toes. Clinical finding important is the pain on the passive movement of the toes. Definitive treatment, you do the fasciotomy. What? Why do palpable pulse not experience? Yes, if you feel the pulse distally and still there is a tense swelling and the pain on passive movement, it is the until unless excluded is the compartment syndrome. So there are traumatic cause, there are non-traumatic or traumatic tibial fracture, crush injury, forearm fracture, high energy trauma, vascular injury, non-traumatic tight cast, burn, snake bite, reperfusion injury, or hemophilia. In the early phase there will be pain, in late phase there will be paralysis. Early phase there is a pain on passive stress, then late phase pulselessness. In early phase there is a tense compartment, which in the late phase lead to muscle necrosis, paresthesia. In the late phase you develop the contracture. 6 P's are important: pain, pallor, paresthesia. Pain on passive stress, pallor, paresthesia, paralysis. These are late symptom. Pulselessness also late, poikilothermia in the end. Management, you do the race. Remove the constriction, assess the neurovascular status, call for orthopedic urgently in emergency fasciotomy. So important points that should be remembered: pain out of proportion to the injury is the hallmark of compartment syndrome. Pain on passive stress is the one of the earliest and the most reliable clinical sign. Palpable distal pulse does not rule out the compartment syndrome. Do not delay the compartment while waiting for imaging or pressure measurement if the clinical diagnosis is clear. Early fasciotomy can save both limb and its function. So, compartment syndrome is a true orthopedic emergency that requires the prompt recognition and the treatment. Diagnosis is primarily clinical and pressure measurements are helpful when the diagnosis is uncertain. Emergency fasciotomy is the definitive treatment and should not be delayed when compartment syndrome is strongly suspected. Delayed treatment can lead to muscle necrosis, nerve injury, Walkman ischemic contracture, rhabdomyolysis, or limb loss. Thank you.